Great. So I have the unenviable position of being between you and your next break. Let me see. Okay, good. I get how this works. So I'm going to talk about two different studies today. I want to give you first a little overview, teeny overview of the office that I represent. I'm in post-deployment health services epidemiology program, and our focus is on population-level inquiry. So basically, our historical focus has been on understanding health effects in deployed populations, primarily from the perspective of what the environmental and occupational exposures have caused for them or have contributed to with regard to their long-term health outcomes. The primary data sources for the surveys, or the work that we do rather, are surveys, both not both, but including web, paper, and telephone-based technologies. And all of those are used in the projects I'm going to talk about today. But we also have access to the healthcare utilization record and mortality data, which helps round out our ability to look at that population-level inquiry about veterans who've served overseas or in combat. The first study is the National Health Study for a New Generation of U.S. Veterans, or the New Gen study for short. Overall, the research objective, as Dr. Rawls suggested for Milco, is broad and not very deep, but it's really a health study of those who've served in operations Enduring Freedom and Iraqi Freedom, to understand medical health, their medical conditions, their both physical and mental health conditions, as well as general health perceptions and functional well-being. This was a multimodal survey using all three modes: telephone, post, and web-based data collection. We oversampled for women at 20%. We were in the field from 2009 to 2011. The response rate was 34%. A familiar question that you saw in Dr. Rawls' slide: has a doctor ever told you that you have any of the following conditions? Patterned on the National Health Interview Study question about lifetime prevalence, we queried for New Gen sinusitis, bronchitis, and asthma. We also asked about the year of diagnosis so that we were able to identify cases who occurred at least after the initiation of the conflict in Iraq and Afghanistan. So this graphic displays the adjusted odds ratios for reported respiratory disease comparing deployed to non-deployed personnel. So remember, this is disease that occurred after 2001. I apologize that it's difficult perhaps for you to see the bottom of the slide, but on the left it's asthma, then bronchitis in the middle, and sinusitis on your right. Both asthma and bronchitis are elevated, but their confidence intervals cross 1, and so not statistically significant. The only consistent finding we had here was for sinusitis, which was both elevated at about 1.3, adjusted odds ratio of 1.3, and confidence intervals above 1. So our next view of these data was to look at self-reported exposure. And we provided people with a checklist that they could endorse. The intro question is, during military service, were you exposed to or did you experience any of the following? And we had included these respiratory or inhalational hazards: dust and sand, burning trash, diesel, kerosene, smoke from oil well fires, and industrial pollution. We also queried smoking history, so we were able to include that in the models. So on your left is a composite variable of any exposure reporting. The blue bars are the deployed, the red bars are the non-deployed. Going across from left to right: dust and sand, burning trash, diesel, kerosene, smoke from oil fires, and industrial pollution. Consistently elevated reporting of exposure by those who are deployed, but but also pretty significant reporting of exposure by those who are non-deployed. These three bars, the deployed, are on your left, the non-deployed on the right. Blue is asthma, red is bronchitis, and green is sinusitis. Generally, what you see here is that those who report any disease are also very likely to report exposure, inhalational exposure. These adjusted odds ratios are restricted to those who were in the deployed group. Across the y-axis, dust and sand on the left, burning trash and feces, diesel, kerosene, smoke from oil well fires, and finally on the right, industrial pollution. All of these are elevated, and if you recall, the level of reporting of environmental exposure is quite high, so it's really not surprising that everybody would have some elevation here. Dust and sand, thinking about the presentations this morning, dust and sand is continuing to lead the pack with the highest adjusted odds ratio, about 1.6, maybe 1.7. So both respiratory exposures and respiratory disease are prevalent regardless of deployment. Those who have deployed to the areas in the Middle East and Afghanistan have higher reporting of both disease and respiratory exposures. One of the conclusions that we came away with was that clearly better exposure measurement is required to understand these associations. I believe firmly in self-report, as Dr. Roll and I think would, we've kind of put yoked our wagons to that star, and I think it's very important, but as the other presentations we've seen this morning indicate, we can do better. So the next study I want to talk about is the Comparative Health Assessment Interview, or CHI, research study. Oopsie daisy. Wow, that was exciting. The objective, not unlike the New Gen study, is looking at the effects of military service, deployment, and combat. And those are specifically called out in the objective because we are using more granular instruments to measure these events. Also looking at not just health, but health and well-being, because we're trying to get a fuller understanding of transition and functioning following separation from service. Again, this is a mixed mode survey restricted to both web and telephone. No paper in this survey. This is individuals who served between 2001 and 2015. Our sample is proportionally based on service during that period. So we have individuals who served early on, and we'll have a longer follow-up period to see their health effects. Our oversample for women is 30%, a little bit higher than the New Gen study. What's important about this study is that we have a civilian comparison group. For this study, we used the GFK Knowledge Panel as our source for civilian respondents. We were in the field in 2018 in the spring and summer. Wow, I see. Okay. So our response rate was about 39% for the core survey among veterans. And you'll note in the 4 sub-bullets here, what's interesting about this response that we hadn't necessarily predicted, but we asked questions to help us get at this, and that is that there's over 6,000 who are OEF, OIF, OND, Operation New Dawn deployed. So these are people who deployed into the theater of operations that we're concerned about this morning. There were also 1,600 people who deployed in support of these operations, but not to that theater. There were another 2,500 who were deployed abroad, but not to that theater. And then there were over 4,000 who never deployed. So we have really interesting opportunity to look at different deployment experiences and their effect on exposure and health. And with the civilian controls, there are over 4,600 people. They answered the same questionnaire, albeit not the questions on military service, but everything else. So with regard to understanding military respiratory and inhalational exposures, we borrowed heavily from the Airborne Hazards and Open Burn Pit Registry questionnaire, which you may be familiar with. These questions are a little bit more granular about respiratory exposure. So did you ever experience any of the following, or were near heavy smoke from weapons, signal smoke markers, or other combat items? That looks like one question. In fact, those are broken out in the responses. We also queried about dust storms and how many days did one experience a dust storm. The red box at the bottom, if you can't see it, when someone endorsed one of these different exposure opportunities. We asked if it was while deployed to operations Enduring Freedom, Iraqi Freedom, or New Dawn, other military service, before or after military service, or didn't experience. So we tried to be comprehensive. When you were deployed to OEF, OIF, continuing the exposure questions for military veterans here, were you ever near a burn pit? So close enough to see the smoke. And did your duties include working at a burn pit? Finally, non-military exposures, which we have had a hard time getting a handle on, whether it was before military service or during occupations pursued after leaving military. So have you ever been exposed to gas, smoke, chemical vapors, or fumes outside the military? And for how long? Have you ever worked for a year or more in a dusty job? To capture disease prevalence, again, relying on the lifetime prevalence question based on the National Health Interview Survey, the right panel are the respiratory diseases that we queried: COPD, chronic bronchitis or emphysema. You can see asthma, sinusitis, constrictive bronchiolitis, pulmonary fibrosis, or other. On the right panel, cardiovascular diseases and cancer tucked in at the bottom there. The remaining items that we queried about health outcome are found in the backup slides, but not included here. So this was not the sum total of the list. So right now we are cleaning the data from CHI and preparing analyses. We're reaching out to collaborators across VA who have interest in the outcomes that we studied, as well as academic affiliates who can contribute to our understanding. And that is the end of my presentation. Thank you.
Again, thanks very much for summarizing two studies. Questions for Dr. Schneiderman? Frank?
What's the time frame that you anticipate for the analyses of these data? I mean, will we see results in the next year, basically?
In the next year. So because of...
Perspective of the next 6 months.
Yeah, right.
Yeah, that's probably...
We could stretch it a year, though.
Yeah, I don't think we're going to hit the peer-reviewed literature with the exposure-related outcomes that quickly. It is a high-priority item, so among those things that are expected to result from this study, it is among the top. Just quite frankly, the methods paper on suicide, because it's a very high priority for the agency, and we ask those questions as well, and exposures. Those are my top priorities. So it's in the first three, I would say.
Yeah, thank you. I'm sorry, I missed the source of the civilian recruits that you were going to have. What was the source of that?
It's we went to a standing panel called the capital G, lowercase f, K, uppercase K, GFK Knowledge Panel. It's a standing panel that's been assembled for research in a number of different fields. I think it's probably used for, I know it's been used in other VA studies. I was just reading one yesterday, but I know it's used for lots of different.
Your assessment about the comparability of that panel to, the deployed and non-deployed service members?
Clearly, those who are in uniform meet a different standard, so it's hard to find a civilian comparison. We matched on age and sex so that we at least know that we're coming close. We had considered other non-uniform samples. My dream here, the holy grail, was to go to MEPCOM, or the Military Entrance Processing Command, and to access individuals who had passed all the criteria for accession but didn't join. But MEPCOM wasn't really interested in what I wanted to do. So, in another study of Vietnam veterans, we did a household sampling, and we identified people in randomly distributed households and selected that way. But we didn't have time for that after MEPCOM fell through. So we identified a panel we felt would work.
I was a bit surprised by the similar types of exposures reported by the deployed and non-deployed. And I wondered your thoughts. Were we really talking about the same types of exposures between these groups? There was some difference in the percent, but not as much as one might have anticipated.
We puzzled over that for a long time as well. I mean, clearly the lowest was burning trash, right? That was the lowest for the non-deployed, but dust and I think dust and sand and fuel exposure were quite high. But if you think about the variety of occupations that folks in uniform perform, those are not unlikely, whether in training, perhaps, in a dusty or sandy environment, whether working in different types of occupations outside, people may perceive that to be dusty and sandy and not necessarily compare that qualitatively to the experience of those who've been overseas in Iraq.
As well, but it still was a bit surprising.
Yeah. Thank you very much.